stream.
Good morning, everyone. Good morning and good afternoon to everyone. We are very much delighted to be here today. And thank you. First of all, I would like to thank WHO for the invitation to moderate this side event. And on behalf of WHO, of course, to also welcome the organizers of the Western Balkan Digital Summit for enabling us to organize this side event and obviously to share our perspectives and experience in this area. The title of the side event is Accelerating the Adoption of Telemedicine in Primary Healthcare During and Beyond COVID-19. And we really believe that there is much of an expertise and experience that we've all gathered, and that many of the aspects that we have been discussing, all of us, throughout the years, that we need more support from the digital tools, from the technology, that actually COVID really accelerated, and we need to use the momentum. In order to do that, WHO is organizing this side event and gathering experts from different areas, from different sectors that are actually indispensable for putting everything together. And we will be discussing today, we will be hearing from the three experts that we have here. You can see them on the slide. I hope you can see the slides. So the three panelists that we have are actually representing, as I said, different stakeholders. First, we have Professor Dr. Kalina Stavrilova-Grivcheva. She is here in the function of the President of the Doctors' Chamber of Macedonia. Then we have Ms. Veronique Ines Trouvenot. She's a co-founder and the director of the Millennia 2025 Foundation, and also Zero Harm, Mothers in Zero Harm Care. And last but not least, we have Ms. Jeta Statovci, who is the member of the Parliament of Kosovo. But before we ask them on their perspective, let me very, very briefly just set the scene on why this side event and why the perspectives of these stakeholders are important. Now, I will not go into the details. I know most of you or all of you are aware and maybe share the same definition with us at this side of the panel, that actually healthcare systems do not exist for themselves. They exist to really provide value and to provide a better health and better quality of life for patients, or for everyone, or for all the citizens, because the ultimate goal of every society is not the wealth itself. It is really the wealth or the well-being of its citizens. And while we are both on the same side with the healthcare professionals and patients, all wanting the best quality of care and the most optimal health for their patients, we still are divided from this goal by one very, very important aspect in life, and that is the cost. And the digitalization and the digital transformation that we have all seen across the last years, especially during COVID, is actually the one that helps us bring more value to the health. It helps us to minimize, or at least we believe it helps us to minimize the costs that we have from nurturing the healthcare systems with human resources, and really replace that bit that can be replaced or assisted. And that is trying to liberate the time of the healthcare providers to spend more with the patients and spend less with papers and administration. But let's see whether we actually succeeded in that. Now, in this digitalization of health and during COVID, we had some lessons that we learned. So we learned that the technology can help us to track the outbreak. That was good. It helped us to really try to diagnose or establish a triage systems using natural language processing, in which doctors were really given a pre-screened information on their patients so that they can skip the step that are just yes or no questions, and they can really submerge immediately into treating the patients. Then it helped really also with the prognosis prediction, where in some countries the CT scans were used to manage the system capacities for optimal case severity based response. Again, another triage, but at the treatment level. But those are the positive aspects that we got. And what was really the negative of all this was that actually the patient-physician interaction was largely reduced, and especially in primary care, it was reduced to 27% of time. It shifted physicians' time to data encoding a lot, up to 58% by some studies. And it created a physical distance. It reduced the possibility for something in sociology they call communicative action. It really removed from us the possibility to be closer to those for which we jointly work towards a better health, and that is the patient or their system. So in other words, can we find a balance? And one of the questions that I think we should try to really look into in this panel is, can we find an effective balance? And can digital health or can telemedicine help us in doing that? Now, I would not go, as I mentioned, in the details of the technical capability or readiness of Western Balkans. You can see from this small graph that is extracted from still unpublished manuals of our group that works back in Macedonia on digital health and digital transformation. But you can see from the graph that more or less the countries in this region, together with some countries that are in the EU, they exhibit a specific relatively high level of technological readiness. But whether the other resources are ready, and those are the most valuable resource of the healthcare system, in fact, and that is the human resources or the healthcare professionals and all the other professionals that we have within the systems, helping not only for healthcare, but also to integrate the social care systems and so on. So I would like to ask our panelists to speak on this. And if we can have, I would like to first invite Professor Dr. Kalina Stardelova-Grivcheva, who is, as I mentioned, president of our Doctors' Chamber of Macedonia. I myself come from Macedonia as well. And Professor Kalina is a dear friend and a great colleague, someone with whom we really worked a lot, and someone who actually was president of the Doctors' Chamber at the most critical time, and that is during the pandemic. So I believe that we can hear some very good experience from you, Kalina. So the floor is yours.
Thank you, Neda. I will just say that as well, I'm director of University Clinic of Gastroenterohepatology in Clinical Center Skopje. And from the very beginning of COVID pandemic, we were twice COVID center. Part of our clinic was COVID center too. So we have a lot of things to share with others. When we are talking about telemedicine, I think there are two levels. Telemedicine between primary care doctors and patients, and telemedicine between primary care doctors and doctors who are on high level, on secondary or tertiary level of healthcare system. For the very beginning, I will just share with all of you that we have tried to make telemedicine better. 8 and 9 or maybe 9 years ago, but somehow it stopped because for us on tertiary level, in healthcare level, it was very difficult to leave our patient and to go to another room and talk with colleagues what they have to do. It's much more easier to use phone calls, to use phone devices like Viber or WhatsApp. Of course, to use computers and mail just to see for communications, for consultation with our colleagues. In this COVID pandemic, technology started more than before. Our primary care doctors can make electronic receipts for the prescription of drugs to their patients. They don't need anymore every 6 months our prescription for chronic patient. Just continue with prescribing if something is not going wrong. They have interaction with their COVID patients, calling them on the phone, video call, making video calls, some kind of telemedicine, what they do. But as a doctor, I always said that we need something more in our communication with patients. Our patients need our touch, need our checking just to feel better, just to feel that you don't do anything else, you are looking up to his condition. On the clinic, we decide to help our doctors with our opinion when it is needed. So we make mail address just for consultation for primary care doctors. They can send their mails, and every morning before our morning staff meeting, we read them and write them the answer when is it needed about some severe patient, because they are looking patients every day more than their families do. That is kind of interaction between doctors and doctors, primary care level and tertiary care level. We don't have enough time to sit on camera and look their data for the patient, but I think this is as well good way to help them with their problems in taking care about patients. So we are going to do it on regular basis, and I think that's somehow not really telemedicine, but it is big help in this special time of pandemic. So that's all from North Macedonia. You're mute, Neda.
Yeah. This is what I'm trying to figure out now. We are in the digital summit and I cannot control my own computer. So why don't I just skip the screen? I think it's better than to have the screen. I really wished to have the three of you on screen all the time, but then I just go back to the presentations. Thank you, Kalina, very much. And I think those two perspectives that you shared between the system and the patient, and then within the system, primary to secondary, tertiary care, are really two big, not really chunks, but two big avenues that we have to consider when thinking about telemedicine. And that is the difference between secondary and tertiary level is really maybe about the level of specialization, but the difference and the gap between the patients and the doctors is quite bigger. And here it is very relevant how the patients and how much they are not only digitally literate, but health literate as well, knowing to transfer or knowing to share with the doctor what they and how they feel. So maybe I think Veronique can join now to tell us more her perspective. She's coming from the Millennium 2025 Foundation and also co-founder of Zero Mothers Die. I got it right this time. And I believe that this is both of these are very big initiatives in trying to bring patients up to speed, if you wish, with the knowledge to the level as much as possible as they can, especially in low and middle income countries with your expertise in Africa, to really try to complement or to contribute to the better health that they have. So Veronique, please, the floor is yours.
Thank you very much. I'm very pleased and very grateful to the WHO Euro office and to the organizers of the summit for their kind invitation. And I'm very glad to be speaking today on a fully women panel. I can tell you that within the area of telemedicine and e-health, that's for years and years that generally I'm the sole women speaking at those panels with a lot of men. So today at the Millennia 2025 Women and Innovation Foundation, we work on enhancing the gender perspectives at all levels within the global framework of the United Nations SDGs, Sustainable Development Goals, 3 in particular in health and well-being, 5 in gender equality, but also with 7 and 17 enhancing partnerships. The foundation is a member of the International Society for Telemedicine and e-Health, which is headquarters in Basel in Switzerland, but covers more than 80 countries to reunite expertise, knowledge, learning from telemedicine and e-health all over the world. We have conferences at international level every year, and during those conferences, the foundation organizes women and e-health special sessions to raise all the concerns, what's happening on the gender perspective within telemedicine and e-health. We're also helping women to publish in scientific journals, articles, and abstracts and editorials on e-health and telemedicine. And I can tell you that this is a really critical exercise for us to find women and for the women scientific to write articles and be published on e-health and telemedicine in scientific journals. We have an initiative, Zero Mothers Die, which is a mobile application free of use. It doesn't cost anything for the users, for the mothers to use it today in 8 different languages and adapted to local utilization and local cultures, like in South Ethiopia, in Oromé, in Amharic, like in Congo DR, in Swahili, and also in Brazilian Portuguese, in the Amazonas and Rio de Janeiro zone. So we have always that perspective that technology, new technologies, innovation is worth if it goes to all hands, in every hand of any user, in particular in any user and any women in the world, from the richest to the poorest, to the lowest locations, in particular in primary health care. Primary health care is not the first medical setting where the women go. In most parts of the world, they first go for traditional healing. And then after they go to primary health care. In traditional healing, there is no telemedicine, but it's coming in mobile apps. Mobile apps are running into those different communities at local level. And that's where prevention and information can reach the women in the local communities. So there is a paradigm shift that where telemedicine is still employed in medical doctors' perspective, in high sophisticated technologies. And it's hard to expand it globally within the UN SDG goals, as I said, to reach all, to leave no one behind. And this should be the motto of telemedicine everywhere, leave no one behind. We have been creating a Women Observatory for e-health at the Foundation in 2014 at Medital in Luxembourg. Within that observatory, we have selected up to today 35 telemedicine and e-health projects managed by women, also by men, but mostly by women, to try to help them enhance their project. With respect to telemedicine specifically, we have 2 projects led by women, one in Newark, in the USA, near New York, and the other one in South Africa. Yet to today, this didn't work because of the lack of funding, the lack of interest, because the lack of recognition, because of multiple factors locally, but also more broadly. There is another aspect that we work a lot on, that to get out the telemedicine out of the doctor's perspective and get it onto the nurses, midwives' perspective. So the telemedicine is an open home for all kinds of health workers, of health professionals. And there is a huge gap still between doctors, nurses, midwives, to enhance promote the use of telemedicine to reach more patients, those where there is no doctor, where there is no nurse, no midwife. This is one of the usages of telemedicine, and more powerful is to get healthcare where there are no health professionals, and give the information, the prevention and the care as much reachable as possible. We created the connecting nurses and creating midwives, connecting midwives networks to ensure that they can work together, enhance their power. And yet the connecting nurses is still working, but connecting midwives is not working anymore. You know how complicated it is to install this innovation in new technologies in the diversity of the healthcare everywhere. Another aspect is that telemedicine still is mainly English dominated. So we have a problem of languages, of adaptation of the telemedicine tools in different local languages to have it really understandable by all the health professionals, but also the users. We need to have it also getting to the youngest generation. The mobile apps are very exciting and very much used by the youngs. So just translate the power of telemedicine into mobile apps that reach the youngest generation to make them the next leaders of telemedicine, the next users, the next creators of new technologies. And to end that, I would like to ensure that telemedicine gets working with telelaboratories, telepharmacy at primary health care. It's not telemedicine embodied in a silo. To make it really useful for the patient needs healthcare, need provision of medication, need labs examination. And with the COVID, we saw that very much. We need not only telemedicine, but a network of teleservices at the disposal of the users and also to the doctors and the health professionals to make it more significant, to deliver better quality of health everywhere in the world. You know, zero mothers die. With the mobile app, we want to reduce maternal mortality by 2030 to zero. Not a single mother should die of being pregnant and giving birth to a baby. So this is all what we aim to do with a global perspective in the efforts of all telemedicine networks to reach better health care, better quality care everywhere in the world and leave no one behind. Thank you.
Thank you, Veronica. Thank you for sharing this very interesting perspective. And actually, Zero Mothers Die comes probably timely as well. Just a little bit side comment. WHO's this year theme on Patient Safety Day is mother and child patient safety, mother and child safety in healthcare. So I think it's very timely. But on the other hand side, I really find it interesting that you mentioned the traditional healing is something that is not quite present in the Western Balkans, but then mentioning the mobile apps, and this is something that really tries to and starts to penetrate on the different levels as well. And there are quite few initiatives ongoing in the Western Balkans related to this, especially in Macedonia. I'm sure Dr. Kalina would agree. For the other countries, there are also some ongoing initiatives, and this is, as I mentioned, on the level between the providers and the patients, so between the system and the patients, which is a different track compared to within the system communication between the levels. But when it comes to sharing data outside of the healthcare system, of course, within the healthcare system, all the providers, they already have their oaths and their professional integrity to protect the data. But then when it comes sharing the data outside of the healthcare system, there are many different challenges and aspects and issues. And I think I would like to now invite the third speaker, last but not least, as I mentioned, but the safeguarding level, meaning the parliament or the governance level, which actually has to make sure that not only the patients receive the best care, but also that their data is protected. They have to take care whether there are enough resources to really implement the ideas and desires that we as societies have. So Jeta, please, the floor is yours.
Thank you very much for your introduction. It's a great honor and a pleasure to be here today. And I definitely wish this was in physical presence, but our circumstances are limiting us on having this meeting virtually. But it would have been a definite pleasure to meet you in person and have this discussion in person as well. So in regard to the topic that we are currently treating, I think that we are two phenomena that are currently happening. There is a need to stay connected, and that need to stay connected is growing. But also at the same time, we have an increasing cost in healthcare, and that is continually increasing. And then I think with the happening of the pandemic, we saw two trends happening as well. And that was that we saw an uptake in telemedicine and also an increase in trust between patients and doctors. I mean, for years, we have seen that there is a need for physical presence, as stated before, that touch, that communication, that eye-to-eye communication, that also helped in, let's say, a mental state or just the sense of caring and having someone for you. But I think that having this need or this must to practice telemedicine in distance while, let's say, most of us were in isolation because of the pandemic, I think that they gradually began also seeing the benefits, and for some low care value, there telemedicine can be an option as well in order to have that monitoring aspect or consultation aspect with the doctor. So we have seen in many countries that there has been an uptake in telemedicine, and there is an increasing trend in trust between, let's say, the patient in regard to receiving healthcare through telemedicine. I think it has definitely its advantages. Let's say it's much more time saving rather than having to travel, and especially if, let's say, people are living in rural areas. It lowers the cost even for the patient, not having to pay for transportation and the other related costs. It's definitely also much more cost effective for the system as well, in terms of, let's say, the visit that it's providing, but also if we increase, let's say, easier access, we're also preventing more serious diseases from happening. That's why this prevention is also linked to a cost-effective aspect of it. So we have a positive aspect in terms of timing. We have a positive aspect in terms of cost effectiveness, and we also have a positive effect in terms of preventness, because if we manage to have this easier communication, definitely that can also increase our level of caring and sticking to prescription and all the other elements that definitely help with your status quo. In regard to Kosovo, and I believe this can be the situation also in the other countries of the Western Balkans, is that we do have easy access to primary care. So let's say in most of the areas, there is a family center. There in every city, there is a main family center. But we have this model of healthcare, which is similar to the UK model, that you only have the family doctor at a family center. So there is no specialist. So it's like a gatekeeper before you go to a specialist, but you can only get family care services. But in regard to access, we have not had any complaints, let's say, in regard to if it's difficult or not. Let's say it's quite decentralized. You don't even need an appointment in order. You just have to show up. And one of the criteria is that you have to be of that certain region, because we have zoned, let's say, areas and neighborhoods for specific, let's say, family centers, so we don't overburden a center with too many requests. So in regard to Kosovo and the need for telemedicine, I see that the element of having access very easily lowers the need for an intensive, development of telemedicine. But I was a student in UK, let's say, and definitely the waiting list was too long just for a quick checkup. And I would go to, let's say, online portals in order to have something just consulted. And that I could see how effective it was, because, it lifted a burden off my shoulder, because I was concerned of a situation, and having that communication before my appointment definitely eased even my mental situation. So I think that's an aspect of it, especially in countries with long waiting lists and difficulties with access. In regard to Kosovo, during the pandemic, we saw some attempts of adapting telemedicine more, and that was the case with psychologists. because beyond the COVID pandemic, we were seeing also a shadow pandemic in regard to mental health. They kind of did, this was more of a self-initiated initiative by psychologists themselves of creating lines and people having, the opportunity of consultation with psychologists, but it was mainly just consultation and having an opinion and thoughts shared between them and the clients that were attending. This was also a project that was supported by the Ministry of Health. But parallel to that, we also thought of having to do something more in regard to another initiative because of the hospitals were overburdened by COVID patients. Some of the other, let's say, departments, they had to stop giving elective services. And that was, creating a challenge for people of other diseases. And that's why we wanted to stimulate more in regard to telemedicine and telecommunication by checking which of the diseases have the most frequent visits. And based on those diseases that have the most frequent visits to the centers, if we could help in designing some kind of this monitoring and communicating mechanism, initially with nurses, if there is a situation that is becoming alarming, and then if there is a need for a specialist to be in contact. We thought that this could be done with initially a doctor and 5 nurses, and having them, communicate with a specific group or specific category of the patients. But this was initially just at an idea stage, and then, situations gradually changed because we were hitting, with the ups and downs of the COVID, it was difficult to plan properly. But I think that definitely that can be a project that we should think also for long term, because if we increase and strengthen this component of monitoring, especially for those patients that can be of big cost to the system and have an increased frequency of the visits, maybe having this mechanism of monitoring and just for them to know that there is someone who is taking care of them and looking at them. And now with the apps, they're automatic when they send you, have you taken your prescription? Have you done your exercise daily? Have you visited your doctor for the last appointment that you had? What is your blood pressure? What is your, and other parameters? And the system then would alarm immediately you if the reported, let's say, numbers were too high. It would alarm the system and, inform the nurses that there may be a patient that is not in a very good situation and needs the proper care of let's say, the specialists. So these were like three initiatives with the psychologists and this digital project that we kind of were foreseeing to be implemented in Kosovo. We do have a lot of youth, so it can be much easier because of their, knowledge in terms of technology usage. So we would hope that this would help with the uptake. So these were 2 components. In regard to what we currently have, we do have a national center on telemedicine, but that leaves a gap in relation to doctor and the patient is mainly doctor and doctor. So it's for them to communicate between centers, either within Kosovo and hospitals in Kosovo or abroad for training and consultation and some kind of advice back and forth. But there is no established mechanism that helps the communication between the patient and the doctor and the system itself. And definitely that can be a good component that we must think, maybe not initially for primary care because of this easy access to doctor, but it can be definitely on these diseases that are of big cost to the system and of high frequency visit to the specialist, just to have that monitoring and coordinating mechanism with them. Thank you very much. That's from my side.
Thank you, Jeta. This was really a health economics perspective on things, and to be fair, I really didn't introduce you properly to the audience, and I didn't mention that you were actually completed your master's at the London School of Economics in health economics, which is a very important aspect of not only telemedicine, but of medicine and of health per se. And I really enjoyed you mentioning, putting emphasis on the time saving, but also cost effectiveness. And I'm not really sure that do we have, or maybe you can share with us later on in the presentation, in the panel, how can we see those costs effectively managed by the telemedicine. But something that I'm a little bit more interested to hear from all of you is you mentioned that there is a telemedicine center in Kosovo that is mainly intended for interaction between patients, between different levels of the healthcare system. And originally we kind of divided this into communicating system to patients and system within on a different levels. So I would like to really hear from the panel, maybe Professor Kalina, if you want to share, what do you think? What is this, say, easier to establish a system with the patients, or is it easier in the sense of prerequisites to establish communication between the different levels of the system? And talking different levels of the system, I really refer to a national system, because maybe later on we can cover the regional dimension as well.
Yeah, differences are between primary care and their patient, which I think we are working good on this level. And of course, our colleagues need help sometimes, just to have consultations, just to send us their data, and we resend them our opinion in cases where when patients do not need to come to a hospital or to be in hospital. I will just say that about COVID-19, because our theme is COVID-19 patients. It is very hard to work with this because it is very unpredictable disease. You have a patient who is perfect with all signs, or lab tests are good, with blood pressure good, and in 15 minutes he's dead. So telemedicine do not work here. We need to see patient, to be in hospital, to check, to make real time when these patients must stay in hospital. And only hours are, only minutes are those who can switch patients from stable to death. That is very tricky to talk about telemedicine and COVID patients. Sometimes they are very stable. It is enough for primary care doctor to talk with them on the video call, to check their blood pressure, etc., just to think about. But things are changing. This infection attacks liver, attacks nerves, attacks brain, attacks not just lungs. And sometimes is very hard for us to divide. Is this just virus infection who attacks lungs, or multi-organ virus infection, which is deadly? We can see in our country there are a lot of dead persons caused by COVID infection. Talking about telemedicine in frame of the country, I think it is somehow organized by mailing, by phone devices. We can see our patients' data, and we must know that in our laws, we have a law about patient rights. That's mean that patient must know everything and must agree if something is going on another level. Our laws are that. So we have laws, we must agree with them, we must work against them.
Yeah. So if I took it right from you, it means that while it might be easier for the doctors to communicate between themselves, to consult on each cases, still we need to inform the patients that this has been, that this is going on. So while the telemedicine
must agree for that.
Yes, so while the telemedicine might be easier in communication, or the technical part between the levels of the system makes it hard from the social perspective of informing the patient and making them aware of what is going on. And then on the other hand side, the primary care and the patients have shown a good case that there can be communication between them that can provide, in many cases, improvement and monitoring of the situation to give a proper advice. But then again, it might also lead to very negative consequences, and that maybe telemedicine is still not quite useful or quite helpful for COVID. That's the message I got from.
Not totally for COVID.
Yes,
it
yes.
Can be, but not always. I will not, if I get COVID, I will not just call my doctor.
Oh, that's good to know. That's good to know from a doctor. Now, Veronica, if you can really tell us and link to the second part that Dr. Kalina was mentioning, if you can really tell us, what do you think with this mobile apps experience that you have? Is the patient literacy or citizens literacy, health literacy, both as digital literacy, relevant? For the digital, maybe we do not want to focus too much because obviously it's related to different skill set, but whether their health literacy in the sense of judging where the specific symptom is 1 to 10, and this is what we say, yeah, the doctors judge the symptoms 1 to 10, whether something is severe or not, but to the patient, any number is 10, because he only judges their own situation. So the subjectivity that the patient brings needs to be alleviated as much as possible by some level of health literacy. So what is your experience of whether telemedicine can work better if we have better health literacy levels, or what is your experience whether there is enough or we need to work more on that?
Yes, definitively, we need to work much more on that. And there is a lot to do. A perspective that I didn't mention in my previous presentation is education, e-learning, and training, definitively. Telemedicine should be included in all medical courses, but also midwives and nursery courses, in order to have this considered as a medical specialty or a nursing specialty, midwifery specialty, and all the students know about it. The problem is that there are not many teachers in the world capable to teach those modules and to give those trainings or e-learning courses in the diversity of different languages and cultures, because this has to be integrated in the local culture of the population to make it really get into the habits and daily habits. And that's where mobile apps are much more easier to apprehend. You know, with a mobile app, you can really reach the person. About literacy, we're amazed to see that even in communities where women are illiterate, anyway, they use their mobile. They're connected in Facebook. They exchange videos, they exchange photos, you know, all the visual aspects help in medicine to be aware of a health risk or a disease or a pandemic. We're speaking about telemedicine here, but remember that in the remotest communities, the radio and the television are very powerful to inform the population and to get people connected and prevented and to have the adequate behaviors with respect to a virus. And this was a real great lesson learned from COVID, is not to only have the focus on new technologies and our innovation, but also combine them with the technology that worked for so long time and that have proven their efficiency. So it's a combination and an adaptation in every local. And don't think that women illiterate don't use mobiles. This is not the real world. They get the mobiles, they use Zero Mothers Die, and they are always helped by people in the communities that are literate. So put a focus on education, on training, on embedding telemedicine everywhere where it's possible, and use it to fight infodemics and fake news. This is another aspect that we have learned from the COVID. We knew from previous diseases and pandemics, but very little. But at the WHO, this was a immense lesson to learn is about the fake news. And telemedicine has to be that tool that provides scientific information, right information to care to the users and the patient. And this is a key element, really, really.
Yes, yes. Thank you so much. And I think it's another very big area that hopefully we can cover in some other panel. But then what I got from your statement here is that we really need to work on education, both to patients, raising awareness, but also among the health providers. And if you allow me, Kalina, these are usually, in the term of the health economists, these are usually interventions with quite a long return period, yes, rate of return. So Jeta, I now would like to ask you to really give us a perspective of, you said cost effectiveness, you mentioned your UK experience. Is it possible that we as Balkans can do better than having those long lists? And is it possible to learn from the experience of those countries to see how our systems can improve and how our patients can use the same approach? Is it feasible for our region to use the online consultations, the ones you mentioned, like chatbots, or I don't know what you actually used? So how much is possible to be more advanced than those, and who will pay the bill, if you wish, in a much late terms, and whether it's really cost effective for us, knowing the level of investment we need to make, especially in education?
So yes, we as health economists, we try to balance economics and health. So economists tend to see all the numbers, not the person behind the numbers. And doctors tend to see the person only and all the finances behind the person. So we try to balance the two perspectives in having an objective judgment regarding the situation. So, I mean, definitely has its pros. I even began my statement mentioning the pros that telemedicine has, but it also is very important in regard to this element of what about access to healthcare? If access is very feasible and easy to reach, and medical centers are not in long distance, and the waiting lists are not too high, because there is an initial investment, all this software, all this communication, the people behind the software, the person sitting there is, of course, there's a cost behind that. Spreading the system, teaching the personnel how to use it, having education campaign for the people on understanding how to use it, maintaining the software feasible and the website up to date and updated and properly working all the time, making the right adaptation. There is definitely a cost behind that. So in centers, if we're seeing that it's working properly at primary care, people have access, people have the services they need, the waiting lists are not too long for them to get care. I think that probably we should focus on these other elements on these specific areas, let's say diabetes or other, let's say, diseases where we could strengthen the component of monitoring using telemedicine and communication, because we are preventing, let's say, a complication of the disease, which in the long term, it would be, of course, affect the well-being of the person, but also affect the economy, because it would mean also more resources spent in terms of treating. So it has two benefits. So I say if we could target a group, let's say with the diabetes, and they are at the early stage, and we invest on this monitoring mechanism and coordinating mechanism and consultation mechanism and prescription mechanism, because we see that a lot of patients actually end on emergency rooms because they are not properly following their prescriptions. So that's, let's say, one of, if we check the reports from the state, that's one of the biggest reasons why so many patients end in emergency rooms. So if we want to use it properly and at this early stage, not to, let's say, transfer too many competencies, because this face-to-face contact is still very important in order to properly judge a situation. That's, I think we should focus on the concept of coordinating and monitoring, and let's say that they have a line and this mechanism, maybe through mobile apps, that controls and monitors and adds these values let's say, of how the situation is progressing, where you have to report that you have taken your prescription correctly every day, and you have done your walking, and you have visited your doctor, and you are feeling well or not well, and these are, let's say, your glucose level and all the other elements that goes into the system in order for, let's say, system also to alarm if the situation regarding the patient is seeming okay, or there need a consultation by a tertiary level, because we know the tertiary level is overburdened with patient. At the same time, it's also costly, but let's say in Kosovo, we have one tertiary center in Pristina, and the patients would have to travel, to come here. And if you are, let's say, at the state that it's at a very, very bad state, using telemedicine, we could have prevented that, or at least, having that proper checkup, or at least just the sense that someone is looking after you. And I thought that this was very important during the time of isolation in COVID, because we were focusing so much on COVID patients, but what about all these other patients who are not receiving their elective, care, and outpatient visits were even stopped because we were trying to prevent a lot of movement between people. So in regards, if you calculate the cost effectiveness, if you're focusing on these diseases that are of a burden to the system, big burden to the system, even financial, I think that there are definitely positive aspects to it. Primary care, if you are in UK, I think definitely, because you'd have probably to wait like 2 weeks to meet your GP for a flu. And by the time your appointment arrives, most likely you have passed your flu, and you can use your appointment first somewhere else. At least that was my experience. But in Kosovo specifically, but I'm assuming also in other Balkan countries, Western Balkan countries, should not be that long. I don't see that. Like in Kosovo, I could easily go right now for a checkup at my family medicine center and my family doctor, and maybe maximum I'd have to wait 10 or 15 minutes.
Thank you so much. And what I take from your statement here is that actually some of the aspects that we as, say, region in trying to catch up with the developed world can have more as an advantage, because we try to experiment. The experience I can share from Macedonia is that really the waiting times for elective surgeries, at least, Dr. Kalina maybe can back me up on this, or if she has a different experience, have been reduced from 17 months down to a week, just by introducing a big system for appointments, and actually for really coordinating the activities, the ongoing scheduling, results sharing, prescribing, and so on, through the very elaborate digital system that we have. And this has really cost effectively helped us for the doctors to use their time more properly, to use their time more efficiently, if you wish. And all of what we have just said, you and me, I mean, just me trying to confirm your statements, is really linked to what you mentioned in the beginning, and that is that health economists are trying not to see people as numbers, but what is even more important is that the doctors try to see their patients without paying attention to the finances. And I would like to close the circle now with Professor Kalina once again, because to us, at least I come from a research and a patient perspective. I didn't introduce myself properly, so maybe I can do that at the end. To us, the health system, of course, does not exist for itself, but the most valuable resource are the human resources. So besides finances, besides cost effectiveness, what is the most important for the healthcare providers if we are to embrace some sort of digital aid, be it a telemedicine, be it artificial intelligence, whatever aid we would like to incorporate into our systems? What would be valuable, and what do not only primary but healthcare providers think and need if we are to work on this together? So what are your thoughts on possibilities that we have?
First of all, I would like to comment. We are not talking about paramedics. We are talking about telemedicine. There are differences. For one healthcare worker, for one doctor, what is making him good is the basic knowledge, upgrading knowledge, and practice. We cannot work without practice. We cannot be good doctors if we don't see our patients, and every day more and more of them. We are sending our patients in foreign centers for diseases for which we don't have enough patients to treat and for ask for help just because they have more experience. That is the most important thing for being good doctor. So after that, you can tell the others, you can talk to the others what to do, but you must have knowledge, upgrading knowledge and experience, and upgrading knowledge every day with regular courses, which are congresses. We do it every day on daily basis, not just in purpose of what once a year to get points for doctor's chamber for license, etc. We have to work. Yes, we have to make it easier access. But for example, in our gastroenterological clinic, if patients wait 4 years ago, 4 months for colonoscopy, now they wait only 1 week. So we make it faster, we make it easier, we made fast-tracked for those who are suspicious for carcinomas, etc. We are making our healthcare system better, but we always have to think about what is, we always said, connection between doctor, trust between patient and doctor. Patient can trust you only when he can see you. Yeah, it is easier with someone who trusts you, can call you and send you his data. But we cannot, in this time, we cannot make it totally online. We need some time to make this all transition easier for our patient as well as for doctors. I think our healthcare system is getting better. It little bit go away from its line because of COVID infection, but COVID infections, I think, make us better in different way. Now gastroenterologists are fighting with every disease, and rheumatologists and neurologists. We are all doctors, and we show that it doesn't matter which specialization you have. You have to turn back to basic level of knowledge and upgrade reading and treating patients. So that's always we have to have in mind that doctor is the one who is carrying a patient situation on his neck.
I couldn't agree more. Thank you very much for this. We are approaching the end. I wanted to have one last question with the one word, but I'm really tempted not to do it because we will overstep the time probably. Anyone in the audience maybe having a question, they can send it to the WHO organizers, and our colleagues from the panel will try to answer them. In any case, I just wanted to draw a couple of lessons here that we got from you. Thank you very much for your extensive expertise on the different levels. Obviously, telemedicine and any digitalization, while it has to serve as an aid to improve the health system, it really requires implementation by diverse stakeholders, and we need everyone on the same page. So to be able to protect the patient, to be able to give them the best treatment, and every of those stakeholders has their own needs in trying to do that, because every one of us wants to go happy and safe at the end of the day, satisfied by the quality of work that they completed. And if that is not done properly, then it makes us not a good system, or it makes us not a responsible society for the health of our populations. And I just want to compliment what Dr. Kalina said with regards to the sorry, they're reminding we have 1 minute, so it's a little bit distracting. But in any case, I just wanted to complement what you said in terms of what the good doctor needs. And our colleague from 150 years ago, Sir William Osler, he said a good doctor treats the disease, and a great doctor treats the person who has the disease. And this is actually what COVID has taught us, and this is actually what our colleagues have been doing. And that it is a very big question whether it can be done online, because the doctor needs to see the person, because the doctor wants to treat the person and not only the disease that that person has. And this is what makes doctors or any health professional a great profession, because they would like to see the integrity of what is going on in order to be able to help that person get in better health. So, but in this sense, just a couple of drawing lessons from this panel, and that is many things are doable. Some have been already done. Economically, many of those will be and can be feasible. However, we need to find the fine line. We need to find the fine balance between what technology can do for us to help us, and draw the line where we start to see that the technology hinders what we can do for each other, because the patient and the doctor, to my understanding, are on the same page, are on the same side, where the patient wants the best for them, and the doctor, obviously, giving the oath at their studies, want as well the best for that patient, the best health, the most optimal care, and so on. So the lesson would be that the good start we had with the primary care and the telemedicine, unfortunately, unwillingly because of COVID, is a good place to learn the lessons of how we can try to find that fine line of still having the most interaction, the optimal interaction, and use the technology to help us not abuse the time of the doctors on writing or digital records, but rather to have more time to spend with their patient. I hope you would agree with me on what I said, but if anyone has anything to add, maybe just a very, very quick, because we have been reminded already about the minutes.
No, I just would say, leave no one behind. There are no doctors are not everywhere, so use the technologies to reach those more isolated and help them to access to quality of care as well. Leave no one behind.
Thank you. Thank you. So I think once again the panel, and looking forward to seeing you in another sitting.
With pleasure. Thank you very much.
Bye-bye.
Thank you. Bye-bye.
Bye.